Yeah, as Roger says, we go way back. Now, is this actually going to work? Yep. So yeah, I set this up for Microsoft Teams, not knowing we'd switch to an alternative platform. So I'm sure there's probably some commercial sponsor deal going on. So yeah, anyone on Teams or Zoom, if you want to open up the chat, but I'm very aware and very conscious of time. So yeah, MSK and Sport and Exercise Medicine in the NHS. Now I'm a fan of the NHS. I spend most of my time there, and deliberately so. And this was a fairly vague title, mainly to talk about getting people in the room and getting people to kind of think. Now, I'm also going to do it in 15 minutes, or hopefully a lot less. Agenda-wise, Sport and Exercise Medicine specialty, NHS, and MDT working. And then hopefully not many questions. Who am I? Well, yeah. I work both at the university and at the hospital. So 3 days a week I work as a hospital consultant. I work as a clinical professor at Loughborough University as well. Conflict of interest, I have both post at BASEM and the faculty at the same time, as many of us do. We spend between two different roles. I'm a trustee for BASEM and I'm the honorary treasurer for the faculty. Now, this is going to be a rhetorical question, because I suspect very strongly that if we talk about what is sport and exercise medicine to people in the room and online, we'd probably get a different answer from everyone. It means very different things to different people. Is there really a single definition? So, Roger, what do you... No, I'm not going to be that mean. After your use of acronyms earlier on, I'm going to just skip you. One quote, which I'm going to borrow heavily from the faculty, is excellence in musculoskeletal medicine, exercise medicine, and team care. And for me, sport and exercise medicine really is a challenge, and the name is often misunderstood by people outside the profession. Sports medicine, from an Australian term, they know something about that in their culture. It's musculoskeletal injuries. In Britain, it means different things, and I spend a lot of my life saying I'm not just working with footballers. So really for me, it's musculoskeletal, sport and exercise medicine, or MSEM. Subject to debate, I'm very aware. Now, really musculoskeletal problems are one of the commonest causes of morbidity in the UK. 1 in 4 people with adults will develop musculoskeletal problems, primary care-wise. 15 to 20% of consultations. Now, long time ago, I was a GP. And I spent most of my time doing musculoskeletal medicine in 10-minute consultations because people self-select. If they know that you've got a GP in the practice with an interest, patients will turn up on your doorstep with their variety of ailments. And I left that a long time ago. And often they're not life-threatening problems. They don't get as much money as cancer or heart disease or diabetes. They're not life-threatening, but they're life-limiting. And probably the one with the leading cause of morbidity and the leading cause of physical reduction, if not inactivity, reduction in activity. And activity is one of the best bets in health that we can do. So we're going to take a very quick diversion, really NHS, sport and exercise medicine, because what is it? Yeah, now we're going to talk blatantly about my department that I've been at for 20-something years. And we work here. So I have a clinic room at the whole department at the Leicester General Hospital, and this brand new not brand new, it's about 8 years old now, the shiny building bottom right is a National Centre for Sport and Exercise Medicine, which are fantastic facilities to work out of. So really for those that aren't really sure where Leicester is, it's kind of in that red dot, that flashing thing in the middle of the country, about as far from the sea as you can get. But it's also convenient because it's about an hour from most places. Now, our department's probably the oldest in the UK. We set up in '93, and we've now got more than 10 consultant clinics a week from our footprint at the General, another 6 from the National Centre, and a clinic from Loughborough Hospital, and one in the Peds department. So it's a broad area. And we've got a door that has seen better days and has taped up. The bit under the silver taping has been there for more than 10 years. We used to co-host it with the Vascular Studies Unit. We long since kicked them out, but the sign's never been changed. And we received about 3,000 or so referrals a year, mostly from GPs, orthopaedics, rheumatology, and predominantly chronic musculoskeletal problems. It's not the acute stuff, particularly post-COVID or whatever phase we are of the pandemic. People are waiting a long time across all NHS services, and we're no exception. One of my colleagues is developing an exercise medicine service as well. And we also have a relatively new, so the last couple of years, acute injury, so subacute review clinic, which is extended physio-led. We're also research active, recruited over 1,000 patients to NHS interventional studies so far, mostly tendon interventions and physical activity interventions. And we do service evaluation stuff for what we do. So the new and the follow-up patients, I'll draw some of the data from. So we've got 5 SEM physicians. Well, we've actually got 4 at the moment. We've got a vacancy. So if any of you are looking for a job as an NHS consultant in sport and exercise medicine, give us a call. We've got a 7-session vacancy that we are looking to recruit. We've got 2 orthopaedic surgeons as well. We still let them in the building. We've got 1 GPSI, and that's how I started a long, long time ago. Originally we had 3 doing 1 session each, and then we've currently got 1 doing 3 sessions. 3 ESPs, 2 nurse practitioners, a podiatrist, so we're truly multidisciplinary. And really half of our activity, half our new patients seen by consultants, but only half. Nearly a quarter are seen by our extended scope physiotherapy colleagues, 8% by our GPSIs, and 17% by our registrars. So really we are a multi-professional team. Our podiatrist doesn't see direct new referrals, they're in-service referrals, and they see about 15% of our follow-ups. And for me, that's the breadth of our clinic is actually quite useful. We draw on people's skill set to actually see things in different lights. So this is data from the service evaluation, the last 43,000 consultations, last 15,000 new referrals, spanning a number of years now. This is our waiting room before pandemic. We've now got screens everywhere that probably will never come down. And 86%, most of the stuff we come from GPs. A number of my own referrals come from orthopaedics or other services. I run a chronic tendinopathy service, but most of our activity is primary care led. And we're a secondary care clinic. There are lots of different models, and talk a bit about that right at the end, but we're a traditional secondary care model where we have referrals into a department. And most of our population now, for me, that's pretty young these days, so 46 years old is a mean patient age. They're young now. And the average symptom duration is more than 2 years. So they've been waiting a long time. These are chronic problems rather than subacute stuff. Whereas on the bottom of my screen, we don't actually see that. So the data excludes the acute injury clinic. So this is the 2-week A&E review clinic. So if you've seen A&E with a soft tissue injury, a load of them are brought back to see our ESP-led acute injury clinic. The data is excluded from this. Mostly lower limb, some upper limb, and there was about 10% or so spinal work, so a broad range of subject. And a chunk of them are tendons, which is what I tend to spend my life doing these days, and bone and joint, muscle tendon. So there's a whole range of different stuff seen in us. And really the causation for me is kind of where I'm getting to with this. When we're talking about sport and exercise medicine, 62% insidious, only kind of 20% were identified as sport. And for me, it's musculoskeletal medicine, MSK medicine, rather than a sport medicine. And I think coming back to the term sport and exercise medicine probably means very different things. So we're BASEM, so British Association of Sport and Exercise Medicine. Don't know. Do we float it as BAMSEM? Probably sounds a bit odd, but musculoskeletal in there somewhere. See people wincing at the thought of the rebranding. So back to topic. So where do we go? So NHS-wise, it's musculoskeletal medicine. One of my colleagues developing exercise medicine. But what are we? Well, we're multidisciplinary. We have doctors, physios, nurse practitioners, podiatrists, all in the same department. We don't have a psychologist. That'll be useful to have. We've not ever got success with a business case for that. And certainly the chronic inactivity, chronic pain aspect of what we do. But really the pros and cons of multidisciplinary work. Well, for me, it really is the more people we get together, the greater the opportunity, the greater the viewpoints, the more learning you have as a team. I learned a lot of stuff working with physiotherapists, with osteopaths, with chiropractors, with nurses. You learn a lot from different people's viewpoint rather than just singing to the choir. It's you get the more breadth, you get more tools in the toolbox. So the more people in a team, the greater the opportunities. And I'm very fortunate. I already work in an NHS department where we've got people that are there. But really that's education, collaboration, peer support. I had a phone call with a colleague the other day who is on his own in his practice, and so he needed to bounce ideas off people. We also develop subspecialty interests. So the pros really of multidisciplinary, it means I can, deliberately or not, develop an interest in chronic tendinopathy, which I'm regretting ever since. One of my colleagues is developing an exercise medicine interest. We have a paediatric clinic, so you can develop those interests if you've got a big enough team. And for the researchers out there, it certainly aids recruitment. If you're only seeing half a dozen patients a week, it's going to take you a long time to recruit patients to studies. But also this bit, the accountability. The more tied into networks you are as a clinician, the more accountable you are, the more people you've got to sense check what you do. And probably the greatest risk to us is increasing isolation. There is a drive to people setting up independent practices, independent musculoskeletal services. You've got GPSIs developing stuff. You've got first contact practitioners. And the more isolated they are, potentially the more risk they carry of that lone working environment. So really the pro of that is the greater connectivity you have, the more accountability you have, the more you can just say, what do you think about? Or just the sense check, or the checking in with you. Because medicine's a tough profession. Physiotherapy probably is as well. The caring or carers fatigue is an under-recognised thing. And the more network you've got, the better support structure you have. But with pros, there are cons. But the other pro actually from this is the greater voice, which I forgot to mention. We are 1 in a myriad of services. So in medicine, so physician specialties, there are 26 physician specialties all shouting their corner. In our hospital, we've got 17,000 employees shouting their corner. The bigger the department, you would think, the greater the voice, although sometimes people have a loud voice if there are only a few people, mainly some surgical specialties, as they're not in the room. But yeah, the greater number you are, the greater the voice. But with pros, there are cons, and it's not all plain sailing. So multidisciplinary teamwork, does it always go well? No, of course it doesn't. You have different people, different personalities. People don't always do what I tell them to do. If only they did, it would be easy. Could you run the risk of intra-team competition with people pulling in different directions or team conflict? Yeah, absolutely, you could. People don't always see eye to eye. A bit like families. Families don't either. But the greater communication you have, hopefully the easier that can be smoothed out. And you have different professions, different professional pressures. So if our podiatrist has got a particularly long waiting list, there are pressures on her that aren't felt by the rest of the team. So being aware of that. But for me, certainly the pros outweigh the cons. So really this is a message for everyone here, is who could you work with? Particularly if you're in a small service. If you're working on your own, if you're doing stuff independently, how could you collaborate? Well, think about locally. Who else is there in either in your service or similar services? Who is there regionally? So the integrated care system, the idea is you're trying to bring people together. Normally, individual clinicians in all shapes and forms tend to get on quite well. As soon as you end up with an organisation involved, people think someone else is trying to do them over, for want of a better polite phrase if we're recording this. Integrated care system, the idea is you're trying to bring everyone together. But also nationally, chat to people. Use opportunities like this to go, oh, you're doing something there. Well, I'm doing that in this area of the country. You're doing something similar. Can we just bounce ideas off of them? Can we set up a kind of a virtual network? Developing informal or formal musculoskeletal networks. Actually, is that something that BASEM has as a professional to bring people together? And for me, that's the advantage of being in the room, is you can bounce ideas off people. The other bit is this, which is the new national framework put on the workforce document supporting the NHS, which is the modernising musculoskeletal and physical, and that has a whole range of different service development types. There's lots of different ways of developing services. We run a traditional secondary care model. There are all sorts of different models out there, and some of the examples are in the document. So for me, it's a very short, sharp talk. Hopefully there aren't too many questions, but certainly if people want to catch up with me afterwards, my email address is there, I'm around. So yeah, over to you. Roger.